We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally, escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Now let's take a look at pathogen-directed therapy for bacteremia. First, let's consider methicillin-susceptible Staphylococcus aureus or MSSA. So for MSSA, treatment of choice is either an anti-staphylococcal penicillin such as nafcillin or oxacillin or cefazolin. And these are considered first choice. They are all superior to vancomycin for definitive treatment of MSSA bacteremia because they have mortality benefits. So, if patients receive vancomycin for pathogen-directed MSSA bacteremia, they're more likely to die compared to receiving these. Now, cefazolin is first-generation cephalosporin, and compared to nafcillin and oxacillin, cefazolin is a much safer option. So both nafcillin and oxacillin are nephrotoxic. So, patients are more likely to develop nephrotoxicity compared to receiving cefazolin. In addition, nafcillin and oxacillin are more likely to be hepatotoxic, so they are more likely to result in increased AST and ALT, so transaminases. And when you look at the dosing, I haven't listed the dosing for these agents here. Cefazolin is dosed every 8 hours, whereas nafcillin and oxacillin are actually dosed more frequently, every 4 hours. So it makes it more difficult to administer. Cefazolin, much better option. Now, of course, if somebody cannot tolerate beta-lactams, then vancomycin would be an alternative option for them. For MRSA bacteremia, drug of choice is vancomycin or daptomycin. Vancomycin is historically more affordable than daptomycin, so people most often use vancomycin. Now that is based on directed cost of acquisition when you compare vancomycin to daptomycin. Now, if you consider that vancomycin requires therapeutic drug monitoring, so you essentially need to pay a pharmacist to basically get vancomycin levels and make adjustment. One could argue that daptomycin might be more cost effective. But regardless, either vancomycin or daptomycin would be treatment of choice for MRSA. And the reason linezolid is not considered drug of choice is because typically with MRSA, we need to treat for at least 2 weeks. And linezolid becomes problematic when you treat for long periods because of adverse effects. So vancomycin and daptomycin are much better tolerated, and they're considered drugs of choice. Now, however, everything we have listed so far is only available as IV. One advantage of linezolid is that it is available as PO, So it would make it easier when transitioning from IV to PO. Now, in general, with MRSA, for the most part, we treat the entire duration as IV. In the POET trial, no patient had MRSA. So although there is some evidence for oral treatment of gram-positive bacteremia, none of those patients had MRSA. So, pretty much standard of care right now for MRSA, for the most part, is IV treatment. Now, for VRE, which is vancomycin-resistant enterococcus, vancomycin, of course, is no longer an option because this is resistant to it. So now you have daptomycin or linezolid. And with VRE, you don't need to treat as, for very long times as we do for MRSA. So typically shorter duration of treatment. So linezolid becomes an option. And when you compare daptomycin to linezolid, daptomycin might have an advantage because, for one, linezolid is bacteriostatic, but daptomycin is bactericidal, so has more potent activity. But also daptomycin is easier because it's in normal renal function, it's administered once a day, whereas linezolid is typically twice a day. But on the other hand, again, linezolid has an oral option, whereas daptomycin doesn't. So, there are pros and cons, but regardless, both of them are considered treatment of choice for VRE bacteremia. And so these were gram-positives. When it comes to gram-negatives, one thing that's very important is treatment of Espl bacteremia. And carbapenems are considered first-line treatment for Espl bacteremia. In fact, meropenem was shown to be superior to piperacillin tazobactam in randomized controlled trial. So people were less likely to die if they were receiving meropenem compared to piperacillin tazobactam. So there's mortality benefit with carbapenem. So now they are considered first line for Espl bacteremia. And cefepime should be avoided because of increased risk of mortality. And this is, regardless of susceptibility. So if the patient has blood cultures growing, let's say Espl producing E. coli, and is susceptible to piptazo and cefepime as well as meropenem, we should avoid using cefepime even though it is susceptible, and we should avoid using piperacillin tazobactam, and we should use a carbapenem because of the mortality benefit. And lastly, other gram-negative organisms, considering they are not multi-drug resistant, because there are other resistant scenarios that are beyond the scope of this lecture. So we will not cover carbapenem-resistant Enterobacterialis. I will refer you to IDSA guidelines for treatment of those infections. Multi-drug resistant Pseudomonas, Cinetobacter, and other multi-drug resistant organisms we will not cover in this lecture. So other gram-negative organisms that are pretty much easy to treat, things like a normal E. coli that's not resistant to multiple drugs, or even Pseudomonas that's not resistant to multiple drugs. So essentially wild-type gram-negative organisms. You essentially choose the narrowest agents based on susceptibility results and PK/PD properties, meaning you want to choose agents that have good concentrations in the blood. For example, you want to avoid tetracyclines in general, because tetracyclines have a high volume of distribution, meaning that they distribute throughout tissue, so very little concentration remains in the blood. So if your treatment if the site of infection is in the blood, you actually want the drug to stay in the blood and not go to other tissues. And things like, doxycycline, tigecycline, these are antibiotics that do not achieve high concentrations in the blood and should be avoided. Now, for oral treatment of gram-negative bacteremia, there are certainly more data when it comes to oral IV to PO switch for gram-negatives. And in general, we want to use high bioavailability drugs such as fluoroquinolones and trimsulfa. So you can see trimsulfa and fluoroquinolones have high bioavailability. Now that's preferred Occasionally, if the patient cannot get these, then and only then oral beta lactams may be considered, but you do have to make sure that you give a high dose to make sure you get enough concentration in the blood. So these are pretty high dose. If you are to use amoxicillin, you want 1 gram every 8 hours, or if amoxicillin clavulanate, it's at least 875 milligram, ideally 1 gram PO every 8 hours. If it's cephalexin, 1 gram PO every 6 hours. Now these 3 are preferred if you are to use an oral beta lactam, and there are less data for the other oral. So if it's best to avoid the other ones due to lack of enough studies showing that you could get enough concentration with cefdinir, cefodoxime, and cefadroxil. But if you cannot achieve, if the patient cannot get these other, you could potentially use this, but you have to make sure that you use higher doses than normally we use. So you want to optimize the dose.